Hello, my name is Dr. Susan Bobbitt. I am a developmental pediatrician here in Saskatoon, and I was asked to put together a little education session looking at the diagnosis of cerebral palsy, or CP. This is my first time recording a presentation like this, so please bear with me. So during this talk, we will cover a number of things. For our pediatric residents, cerebral palsy is listed under the Royal College Pediatric Competencies. But more importantly, we'll be going through a definition of cerebral palsy, risk factors, how we diagnose, motor types, parts of the body affected by CP. We'll touch on some of the motor classification systems that we use, associated impairments, and then we'll end with some evidence-based treatments and further directions. All right, so to start, the definition of CP is a bit lengthy. So CP describes a group of permanent disorders of the development of movement and posture causing activity limitation that are attributed to non-progressive disturbances that occur in the developing fetal or infant brain. So the most important pieces of this diagnosis are that these are permanent disorders. They affect functional ability, so functional movement and posture, and they cause limitations in activities of daily living. The other piece is that they are attributed to non-progressive disturbances or injuries. So progressive disturbances or injuries are not part of this definition, and they need to occur in the developing fetal or infant brain. So in general, this is usually limited to under 2 years of age. Okay. The motor disorders of CP are often accompanied by disturbances of sensation, cognition, communication, perception, and/or behavior, and/or by a seizure disorder or epilepsy. So how common is CP? So CP is very, very common. So we estimate that 1 out of 400 individuals in Canada will be diagnosed with CP. It is the most common physical disability in children. We know that there's no single cause, but there have been a number of risk factors identified to help lead us to this diagnosis. The average age of CP diagnosis in Canada is about 18.9 months, give or take 12 months. Babies can now be diagnosed as at a high risk of CP at 3 months of age. And the reason we do this is that earlier detection often ends up with earlier intervention. There are many evidence-based interventions for cerebral palsy, and new guidelines will be available soon. So what are the risk factors for cerebral palsy? So I like to break this into categories. So prenatal, perinatal, postnatal, and late complications. So in that prenatal group, we know that insufficiency of the placenta can increase risk factors for hypoxia to the fetus, as well as ischemic injuries. Certain infections or toxic exposures during pregnancy can significantly increase risk of CP to the baby. The mechanism to this seems to be due to a fetal inflammatory response. So inflammation triggered by infection or fever or toxins can damage the unborn baby's developing brain, resulting in the motor impairments down the road. Things like thrombophilia in the mother can also predispose that injury. And then things like IUGR, which can be kind of traced back to placental insufficiency. The next kind of group we look at is perinatal risk factors. So for the NICU, this is where we would encompass the prematurity. The literature shows us that there are increasing incidents of CP diagnoses with decreasing gestational age. Other things in the perinatal period are things like hypoxic ischemic encephalopathy or maternal infections, so things like chorioamnionitis, other infections that happen around that time of delivery. We then look at postnatal complications, so things like jaundice leading to kernicterus, which is bilirubin crossing that blood-brain barrier and often depositing in the basal ganglia. Things like intraventricular hemorrhage and sepsis, meningitis, again, infection that can cause inflammatory responses in the brain or brain injury to the brain. Late complications are more around those acquired brain injuries, so that can be due to accidental injury, non-accidental injury, or the gamut. So how do we diagnose CP? So this is a bit of a busy slide, so I'm going to walk you through it. The American Academy of Neurology recommends a stepwise workup to aid in the diagnosis of CP. The first step is generally recognition of a permanent non-progressive disorder of motor function in a child, and we do that through history and physical examination, focusing on any known risk factors. So if you look here on the left side of the screen, we have a bit of an algorithm. So we ask the question, does an infant have risks for cerebral palsy? We look at yes or no. And then we look down at that. Does the infant have abnormal motor development? So in that piece, we're looking at that non-progressive disorder of motor function. If imaging studies are available, so in some infants we may have perinatal imaging studies such as fetal anatomy surveys or newborn head ultrasounds. We look at that for any kind of evidence of injury. If those imaging studies do not show a cause for the clinical findings, further neuroimaging may be obtained. Brain MRI is the recommended imaging modality and is preferable to CT scan given its higher specificity for identifying intracranial abnormalities. As listed under the neuroimaging picture on your screen, there are a wide range of abnormalities that may be seen on brain imaging in patients with CP. If imaging results are normal or non-diagnostic, the final step is to consider screening for inborn errors of metabolism and carrier states for genetic disorders that might explain the patient's symptoms. Okay, so we look at risk factors, we look at the history and physical examination, and then we're looking at assessment tools of how to assess that motor development, which we will get into in future slides. So the Hammersmith Infant Neurological Exam, or the HINE, is a standardized neurologic assessment tool for children 3 to 24 months corrected age. The HINE consists of 26 items and is subdivided into 3 sections, so physical examination, motor development documentation, and behavior state evaluation. The HINE has a 90% sensitivity specificity for detecting CP. And the beautiful thing about the HINE is that this is an assessment tool that is accessible for all clinicians. So not just physicians, but nurses, nursing practitioners, physical therapists, occupational therapists, people that are trained in this assessment tool. I have linked a YouTube video here that goes through how to perform the HINE. It is quite lengthy. It's about 45 minutes in length. So I won't be reviewing that during this presentation, but it is available for review should you be interested and wish to gain more training in this tool. So once we get to a diagnosis of CP, we then ask ourselves, how do we describe this diagnosis? How do we describe this so that other clinicians, other people can understand what we are reporting? So there are 4 main types of CP: spastic, dyskinetic, ataxic, and mixed. Spastic cerebral palsy is the most common type of CP. It will account for about 70 to 80% of cases. Spastic means that the affected muscles are stiffer and tighter than normal. How those stiff muscles present varies from person to person. Spastic CP arises from damage to the motor cortex portion of the brain, which is indicated here on this slide. Dyskinetic cerebral palsy is kind of the next common type in combination with ataxic. So in this type of CP, the muscle tone can suddenly change from high, so tight muscles, to low, floppy muscles, causing uncontrolled involuntary movements or spasms. So dyskinetic CP arises from damage to the basal ganglia, and if you'll remember back to previous slides, a kernicterus, which is a catastrophic side effect of jaundice, is the type of injury that generally tends to cause this dyskinetic presentation of cerebral palsy. Ataxic cerebral palsy is the least common type of CP. In these kids, movement is often shaky and balance can be poor. Children often have difficulty with the fine motor control, movement, and may have a tremor that increases with activity. Muscle tone in these kids is usually low, so they're often described as slightly floppy, and this can make sustaining upright postures such as sitting or standing difficult. This is generally arising from damage to the cerebellum portion of the brain. And then the last type of cerebral palsy is what we call mixed CP. So mixed types of CP feature more than one type of the previously described cerebral palsy forms. Next, we need to look at how we describe cerebral palsy, or what part of the body distribution is affected. So when we talk about CP, we can talk about monoplegia, which is one limb affected. Usually this is one arm. We then consider unilateral CP or hemiplegia, which means one side of the body is affected, either the left side or the right side. In bilateral CP, we're describing involvement with both sides of the body, and this can be broken down into diplegia, where the legs are more affected than the arms. In these kids, the trunk is typically also involved. Quadriplegia is also referred to as total body involvement, and this is where the whole body is involved. This includes the trunk, head control, and often control of the muscles of the face and mouth. So this right here is a classification tree for the subtypes of CP. It's a nice algorithm that you can work through to help try to determine how to describe the presentation of the child you're seeing. So the first question in this tree is there persisting increased muscle tone in one or more limbs? The answer to that is yes or no. If the answer is yes, you're then asking yourself, are both sides of the body involved? And you can come out with spastic bilateral or spastic unilateral. If we find that the tone of the child is varying, then we're looking at the dyskinetic or ataxic forms. And if we're looking at reduced activity or increased activity, we're looking at dystonia or choroathetotic cerebral palsy. After establishing the diagnosis of CP, various instruments can be used to evaluate the severity of CP in response to treatment. The most widely used evidence-based tool is the Gross Motor Function Classification System, or GMFCS. The GMFCS is a 5-level classification system that describes the gross motor function of children and youth with CP on the basis of their self-initiated movement, with particular emphasis on sitting, walking, and wheeled mobility. Distinctions between levels are based on functional abilities, the need for assistive technology, including handheld mobility devices or wheeled mobility, and to a much lesser extent, quality of movement. The GMFCS contains 5 age bands, and levels are quite stable after 2 years of age, and children are not likely to change levels even following intervention. This slide right here is a pictorial representation of what the GMFCS looks like. So as you can see, it breaks it down into the 5 levels, so level 1, level 2, level 3, level 4, and level 5, where level 1 are the kids that are least affected, so walking without limitations, all the way up to level 5, where kids generally have quite significant impairment and require transportation in a manual wheelchair. This also includes a description of how we make distinctions between the different levels. So for instance, for level 1 and level 2, compared with children and youth in level 1, children and youth in level 2 have limitations in walking long distances and balancing. They may need a handheld mobility device when first learning to walk. They may use wheeled mobility when traveling long distances outdoors and in the community, or they may require the use of a railing to walk up and down stairs and are not as capable of running and jumping. On the right side of the screen, you'll also see a pictorial representation of the descriptors and illustrations of the GMFCS levels between the 6th and 12th birthday. The next classification system that we use is called the MACS, or the Manual Ability Classification System, which has been developed to classify how children with CP use their hands when handling objects in daily activities. The classification is designed to reflect the child's typical manual performance, not the child's maximal capacity. It classifies what children do when using one or both of their hands for activities, rather than assessing and classifying each hand separately. This algorithm is used to help distinguish between the 5 levels of the MACS, where level 1 is children that handled objects easily and successfully, while level 5 describes children that are not able to handle objects and have severely limited ability to perform simple actions requiring total assistance in fine motor activities. So when we look at cerebral palsy, we also recognize that there are a number of associated impairments that come along with this diagnosis that we need to monitor and treat for. A large number of children with CP are reported to be limited by pain. Common causes of pain include increased muscle tone, muscle fatigue or weakness, ill-fitting orthotic treatments, so things like braces or casting, as well as GI causes that are common in the general population, like gastroesophageal reflux disorder or constipation. We should be mindful to ask children and parents directly about pain during clinical visits and to screen for potential sources when needed. Seizures or epilepsy occurs in about 25% of children with CP and may occur at any GMFCS level. Children with spastic unilateral CP due to stroke or cerebral malformations are particularly vulnerable to seizures, whereas children with spastic bilateral CP from periventricular leukomalacia, or PVL, often have a motor cortex that is relatively spared, and seizures tend to develop less frequently. The side effects of anti-epileptic medications, such as sedation, affecting learning and behavior during the day, may further compound the developmental effects of seizures that are not well controlled. Kids with CP are often at risk of global developmental delay or intellectual developmental disorder, which are diagnoses that include delays in multiple domains of development or delays in thinking and learning skills that are lifelong. Speech and language disorders are quite common in children with cerebral palsy, and that often has to do with differences in the motor cortex as well as the control of the face and the oromotor muscles. Children with CP can present with a wide range of oral motor feeding challenges and may also be at risk for overweight or obesity due to decreased physical activity. They're also at increased risk for developing cardiovascular and metabolic diseases in adulthood. Hearing and vision is very important to assess for in children with CP. Children with CP commonly present with refractive error, strabismus, and visual field loss, reflecting the patterns of cortical or white matter damage. When children experience delayed weight bearing, secondary to delayed motor development, they can have alterations in muscle balance around the hip, and the hip joint can develop signs of subluxation or dislocation. Hip surveillance is something that should include clinical examination and a radiographic anterior-posterior view of the hips, because its displacement can occur without signs or symptoms. Children with CP are also at risk for scoliosis due to the muscular imbalance during rapid growth periods such as puberty. This condition is usually mild but does require monitoring. And then hypertonia. So hypertonia can be treated using a variety of management options and requires consideration of child and family goals, the location of hypertonia, as well as functional classification. This right here is a table that goes through some of the different assessment tools for assessment of chronic pain interference or coping in children with CP. These tools have quite significant content validity and are a place to start in getting this history. As mentioned previously, children and youth with CP are at higher risk for their hip sliding out or being out of joint. The CP Hip Surveillance Clinical Care Pathway is an evidence-informed guideline used to support the early detection and management of hip problems. This pathway was put together by the Kids Rehabilitation Team at the Holland Blue Review Hospital in Toronto and gives a good guideline in terms of how to screen, how to verify the GMFCS level, and what management might be. So tone management, I like to touch on this because often this is a question that clinicians have for us. So there are another number of options available for management of tone with children with CP. So intramuscular onabotulinum toxin A, or Botox, has been used for decades to reduce spasticity and deformity and improve mobility and pain control in children with CP of any severity. A 2019 Cochrane review indicated mixed outcomes. The optimal age at which to initiate Botox injections is controversial, but typically first injections generally occur between 18 to 24 months of age. There are European consensus guidelines that provide recommendations for the use of Botox injections in children with CP, including indications, dosing, and techniques, and I have linked them here. Systemic antispasticity medications such as baclofen and diazepam are short-acting medications that help relax muscle groups, but they come with many adverse side effects like sedation, dizziness, confusion, nausea, lowered seizure threshold, and CNS depression. Although these medications may be necessary in severe cases of CP, so typically kids that are classified as GMFCS 4 or 5, there's limited evidence to support their long-term use given the adverse events. Selective dorsal rhizotomy, or SDR, is a neurosurgical procedure where selective nerve roots are severed to reduce tone and maximize motor control. Typically, this procedure is used for ambulatory spastic diplegia in children with GMFCS level 2 or 3 CP, but more recent data suggests it may be helpful in even more severe cases. So one of the big things that we like to focus on in cerebral palsy are the 6 F's. So function, family, fitness, friends, and fun, as well as future. So these are things that should be at the forefront of our assessment of kids with CP and lead discussions with families and their children in regards to accessing next steps. So I just want to leave you with this question of, is this cerebral palsy? So a 2-year-old with history of a stroke on antenatal ultrasound and typically developing motor skills, what do you think? A 9-year-old with history of kernicterus and significant tremor with fine motor activities? A 16-year-old with quadriplegia post-traumatic brain injury at 12 years of age? A 14-year-old with difficult doing the pizzicato on her violin? I want you to reflect on these, and I will provide the answers to your nursing leaders. Thank you so much for joining me today. I am very happy to answer any questions. Please reach out if needed, and thanks for the opportunity to present to the NICU nursing group.